Welcome to today's CMHC webinar, Accelerating Diversity, Equity, and Inclusion in Cardiometabolic Health, latest updates from leaders in the field. We're honored to have our three esteemed faculty joining us for today's discussion. Today's moderator is Dr. Keith Ferdinand, the Gerald S. Bernstein Endowed Chair in Preventative Cardiology and Professor of Medicine at Tulane University School of Medicine in New Orleans, Louisiana. He is joined by Dr. Rachel Bond, Assistant Professor, Department of Internal Medicine at Creighton University School of Medicine, as well as Dr. James Gavin III, who is Clinical Professor of Medicine at Emory University School of Medicine. Dr. Ferdinand, we're pleased to have you. Welcome.
Oh, thank you for such a kind introduction. Today's webinar is going to be a conversation between myself and my colleagues, Dr. Bond and Dr. Gavin, and we're going to discuss some of the changes that are ongoing in cardiometabolic health and outcomes, but specifically address those issues related to racial ethnic disparities and outcomes. The data is being presented as our own. We're not representing our organizations per se, and there will be a recording of this webinar posted in the CMHC's website in the upcoming weeks. There is no CME for this particular session. This is something that we do in honor of Black History Month and upcoming Women's History Month. We focus on those social determinants of health where people work, live, play, and pray. And we integrate cardiovascular disease and diabetes, cardiometabolic health, looking at women's health across the lifespan and strategies, how we can work from various aspects of our specialties and interests to prevent disease and disability. You know, everything's not progress. I've been practicing for decades, but health life expectancy, while it's improved, we still see the white-black mortality gap, specifically driven by cardiovascular disease and diabetes. African Americans have worse outcomes, shortened life expectancy, more complications related to chronic kidney disease, heart failure, blindness, peripheral vascular disease, amputations. And it's important for us to recognize that although you may not personally self-identify as a person of color, it's a problem for all of us to address. And we're going to try to sensitize that this is not a Black issue or an Hispanic issue or an Asian American issue. It's an issue for all of us in this society. Now, the reasons for these disparities are complex. Very much of it driven by the social determinants, the socioeconomic status, access to healthcare, health-seeking behavior, and real bias in the healthcare system. But together, I think we can work together to overcome these long-standing and unacceptable disparities in outcomes in our society. The data exists. This is not social science. We're not talking about feelings or bad Instagram posts or what someone said on Facebook or Twitter. These are real data related to death and disability in our society, and the Cardiometabolic Health Congress is using this opportunity to tackle these racial ethnic disparities. We do it year-round, but we're highlighting it here in February because of Black History Month. So let's go ahead and go straight for it. Let's go with Dr. Gavin first. Dr. Bond, we're going to ask you the same question. And that's, Dr. Gavin, what drove you into this idea of addressing disparities? Now, you're an endocrinologist, is that correct?
That is correct. And actually, I didn't learn until I was 26 years old. I was a postdoc at the NIH. What disease had killed my beloved great-grandmother? It was diabetes. That revelation changed my entire career direction. The more I learned at that time, the clearer it became that this was a disease that was doing far more than ravaging my family. It was ravaging people of color writ large. And little did I know how many layers of society had given rise to this disproportionate expression of diabetes and other chronic diseases. Genetics, yes, but the history of how we live and developed in this country, the wealth gap, redlining, where people live, and what we know now are those things that are called the social determinants of health. And then we also had limited opportunities to become healthcare providers and advocates for structural changes in medical education and healthcare delivery. And when those things became clear to me, I really launched into the direction of making my life's work. How do we get our arms around eliminating these kinds of disproportionate influences of chronic diseases in all of these different populations?
Now, Dr. Gavin, you're a former president of the ADA. I'm going to let Dr. Bond give her opening remarks, but I'm going to come back to you on this concept of the social determinants of health, and specifically in the field of diabetes. I understand there's been some new publications related to the standards of care and how the social determinants of health impact that. Is that okay?
Absolutely.
Dr. Bond, all of us in cardiology train to look at devices and interventions and different types of pharmacotherapy, but you've brought to the forefront this idea of examining women's health across the lifespan, and you focus especially on some of the disparities related to pregnancy-related cardiovascular disease. How did you get into this? Why did you go into this field and then start to address even more in a focused manner these disparities?
Well, first and foremost, thank you, Dr. Ferdinand, for the opportunity to be on this esteemed panel today. So I think it's very similar to Dr. Gavin's story in that it was my own family's lived experience. I always reflect back to my grandmother, who was misdiagnosed for probably a decade of her life when it came to something as simple as diabetes, which then, unfortunately, because she was misdiagnosed, led to premature cardiovascular disease in the setting of a stroke. Because of that, when I decided to really commit my life to medicine, I decided to go into a field that would help to change those statistics. And it wasn't through, I would say it was more so through my own education that I began to realize how glaringly obvious these disparities are when it doesn't just come from race and ethnicity, but also sex and gender. And as such, seeing that many of the things and many of the conditions that could occur during a woman's reproductive years, meaning as early as maybe their adolescence up until their 20s. These are largely preventable conditions, but conditions that we don't actually begin to think about probably till later on in life, or even at all, even for us as clinicians. So I personally wanted to dedicate my career to focusing in on a lot of these sex, ethnic, racial disparities, knowing that these are the populations that are impacted the most, particularly women of color, as an example, who probably has the greatest risk when it comes to cardiovascular disease due to these high rates of cardiometabolic risk factors. And as such, I dedicated a large portion of my professional career to that.
Your passion, your knowledge, your commitment in this area is something that all of us are really very pleased to see, and I hold in high esteem your work. I'm going to ask you later the same thing that I said I was going to ask James later, is why everyone should be interested in this. You know, if you're not a self-identified woman, why do you care about women's health? So I'll ask you that, and same with you, James. If you're not a member of a person of color, or you don't have diabetes, you know, why should this issue be something that's important to you? But before we do that, James, I said I was going to give you the opportunity to tell us why the social determinants of health, specifically in diabetes, is really a newsworthy item because of the new standards of care. What happened there?
So Keith, I am pleased to report that in this year's January edition of Diabetes Care, which, as you know, contains each year the standards of care in diabetes. So this is for circa 2023. In the very first chapter of content entitled Improving Care and Promoting Health in Populations, right behind the section on population health, there is the section that's entitled Tailoring Treatment for Social Context. This is a new direction for our standards of care. There are A and B level recommendations for acknowledging and addressing the social determinants of health in diabetes. Now, in the accompanying narrative, I think it's worthwhile to take a minute to actually say what they say. Health inequities related to diabetes and its complications are well documented. They are heavily influenced by social determinants of health and have been associated with greater risk for diabetes, higher population prevalence, and poorer diabetes outcomes. Social determinants of health are defined as the economic, environmental, political, and social conditions in which people live and are responsible for a major part of health inequality worldwide. Greater exposure to adverse SDOH over the life course results in worse health. The ADA recognizes the association between social and environmental factors and the prevention and treatment of diabetes and has issued a call for research that seeks to understand better how these social determinants influence behaviors and how the relationships between these variables might be modified for the prevention and management of diabetes. Now, this is really paradigm shifting. But there's a couple of things, Keith, I just want to point out that, we actually are talking now about how these considerations need to be integrated into our care strategies, even while recognizing that we don't even discuss the social determinants in our evaluation of patients that we encounter. So we've made some progress, but there's a lot of work need to be done, because two things I would finally point out. There was no focus in the current standards of care on the role or the need for technology competence or technology acumen. And as we know, in many chronic diseases, that's really important. One of the outstanding omissions is in the chapter on cardiovascular disease and risk management. There's no mention made of to what extent are the social determinants of health reflected as contributions in the ASCVD risk calculator. I think that is an astonishing admission, and it's an area that begs for our collective attention.
Dr. Gavin, one of my areas of interest for decades has been hypertension. And we know that people who self-identify as Black have more hypertension, more severe hypertension, and poorer control. But if you really look at the NHANES really closely, the worst outcomes, the prediction, not having an identifiable source of care, not having insurance, not having been seen by a healthcare provider within a year. That's 5 times more predictive than self-identified Black. So it's not important to just say, is a person consider themselves a Black patient or an Hispanic patient? It also is the milieu, the environment where they work, live, play, and pray. And I think you've hit it something very, very important for us. Now, in the field of women's health, we know that some of those social determinants are very, very predictive. But Dr. Bond, I just saw some recent data, and I'm not moving away from the social determinants, but specifically related to pregnancy-related complications, that even Black women who are mean still have a higher rate. How do you explain that?
Yeah, and I think it's important to put into perspective that the maternal health crisis, and there is a crisis in the United States as it stands is leading the way in terms of an industrialized country with the highest rates of death from pregnancy that are largely preventable. And the vast majority of those deaths come from cardiovascular disease. What we know is that this is disproportionately impacting women of color, specifically Black women, who are dying at 3 times the rate of their white female counterparts. And one thing that is important to highlight is that that's across sociodemographic factors. So as you very nicely mentioned, Dr. Ferdinand, Black women who have graduate educations are dying at higher rates than white women who may not have graduated from high school, as an example. And we see this also translating into the high rates of infant mortality. So it still does stem from those social determinants of health. And one really large social determinant of health is the fact that it's not race, but it's the social aspect of race, probably in the form of racism, that's leading to these disparities that we're seeing when it comes to both maternal health as well as cardiovascular health, and the intersection of both when it comes to women's health in particular.
We'll hear politicians and pundits say something like this, and all of us have heard this. The mean life expectancy in the United States is about 16th among industrialized, westernized societies, including Japan. And that shows that we have a very distorted healthcare delivery system. Here's what I do with that particular piece of information. If you have means, if you have an identifiable source of care, if you are referred to specialists like yourself and Dr. Gavin appropriately, you live just as well in the United States as you do in France or Japan. The reason our life expectancy is so poor are these disparities. This is not a side story. This is the story about healthcare delivery in the United States that we need to address. So I'm so pleased to hear both of you tie in all the various structural inequalities and social determinants that then lead to these poor outcomes. Now let's talk about one group of drugs, and we're not naming any specific medications or devices, but they're new drugs which Dr. Gavin came into my life as a person who was coming to cardiology meetings. We didn't even know he was an endocrinologist. We said, who is this guy? And one time after him doing this for months, maybe even a year or so, I turned to him and I said, James, I think treating diabetes is really important. He fell out of his chair because he had been trying so hard to tie diabetes and cardiac disease together. Well, it's happened now that we have agents which were originally used for diabetes, the SGLT2 inhibitors, GLP-1 agonists, that now appear to have cardiovascular and cardiorenal protective aspects. So I'm going to ask you first, Dr. Bond, and I'll ask Dr. Gavin. The problem is these medicines are very expensive. So are we getting now advancements in pharmacotherapy with less access? We widen disparities, make it worse. Those who have means get it, those who don't get it. How do you address that, Dr. Bond?
Yeah, well, the short answer to your question is yes, right? It does widen those disparities, unfortunately. And to answer your question about how do we get this into the hands of the people who need it the most, including the Black and Brown community, it's a challenging question, but I think that it does begin with legislation. We need to ensure that coverage at the minimum from a Medicare perspective will then, because we know Medicare tends to translate into commercial insurances. If they cover, all of the insurances will follow suit. So I think at a minimum, there are cardiovascular societies, endocrine societies, all medical societies, as well as societies outside the scope of healthcare that are really lobbying to ensure that insurance companies are covering these largely preventable medications that could lead to lower outcomes when it comes to cardiovascular disease. We've heard quite a bit in the media more recently about the GLP-1 agonist, even when it comes to anti-obesity medication. And we know obesity in of itself is an epidemic and it's a chronic medical condition. So I will say that there's value in understanding that in order for us as clinicians to treat these chronic medical conditions, we need to make sure that we're providing equitably the right management, be it lifestyle, medication, or surgical options for each and every one of our patients. That way, we can hopefully lead to lower outcomes when it comes to this largely preventable condition like cardiovascular disease.
Dr. Gavin, I gave away a little bit of our own personal history, how you came to cardiology meetings on a regular basis to try to tie in diabetes and cardiovascular disease. And now we have agents that do that. But are we setting up a barrier to health equity because of cost?
Yeah. So there are a number of things. And if you just indulge me a second, because people have started to look at this whole issue of how are these newer agents, because of their really powerful spectrum of impact across the cardiometabolic spectrum, how are they being used? And there was a very interesting paper last year, in the Journal of Diabetes and Its Complications. And just a couple of things from that. They looked at a population sample of about 400,000 patients on GLP-1s or SGLT2 inhibitors. Now, they were relatively balanced in terms of the population groups that they were looking at. Overall, GLP-1s and SGLT2 use were higher in patients who were on private insurance. Probably not a surprise, because the use of these drugs was lowest in Medicare-only insured patients. Now, patients who were visiting cardiologists had a twofold higher rate of use. Patients visiting endocrinologists had up to a 3.5-fold higher rate of use. If you were seeing both of those specialists, which is an argument for why we need to have more integration in terms of our approach to patients with diabetes. If you were seeing both, you had up to a 5-fold higher rate of use of these drugs. So there is a clear disparity in the pattern of use of these agents, improved by the type of healthcare insurance you have and by the type of care that you have access to, particularly if you're part of an integrated team of healthcare. We don't have all of the insights that we need into the causes of this kind of treatment inertia, but given the power of these drugs to change outcomes, Keith, we really need to be looking into it more deeply and more broadly.
You know, that's a really powerful message. And you used the word, which I unfortunately didn't use earlier, and I should have. It's team-based care. We are physicians. However, we can't do this by alone. We need the nurse practitioners, the advanced practice nurses, the RNs, the PAs, the community health workers who may not even have an advanced degree. And we can talk a little bit later about community-based interventions. James, I know you've worked in an area, and here in New Orleans at the Healthy Heart Community Prevention Project for decades, we've gone to barbershops, beauty shops, faith-based places, even sporting events. So we'll go back to that. But it's team that's important. It's not just the doctor. It's not compliance. It's working together in shared decision-making. It's not calling an electronic prescription that a patient can't afford and then chiding the patient when they come back for their follow-up visit, they didn't get the medication. You agree with that, James?
I completely agree with that, which is a theme that we have to keep addressing in every one of these occasions that we have like this. That's a theme that is worth hammering because without it, we don't win.
Now, one thing that we have discussed, and I want to tease out a little bit more, and Dr. Bond, I'm going to let you take the lead on this, is we talk about specialties and disease, but we know people don't really segregate their bodies that way. They don't walk around and have a cardiology disease or have an OBGYN disease or have an endo disease. In fact, we don't even talk to people about it. We don't call them diabetics anymore. It's a person who is living with diabetes. So how do you segue that in women's health, especially related to pregnancy related complications and conditions, to not just having the cardiologist, but also bring into account the obstetrician or even the layperson who's helping the woman in the process of navigating a pregnancy? How do you integrate those things?
Yeah, no, that's a wonderful question. And I like the term teamwork as well. We know teamwork makes the dream work, right? So when it comes to, let's say, maternal health in particular, we know that that collaboration is such an important aspect of what's going to lead to the reduction in these disparities during not just the period of when the woman is actually pregnant, but most importantly, leading into the pregnancy, and even more importantly, after the pregnancy. We know up to 1 year after someone delivers, they're at the highest risk of having poor outcomes, especially when it comes to cardiovascular disease. So what we are now doing in the cardiology field is really working collaboratively with our obstetricians to try to optimize these patients' cardiometabolic risk factors before they decide to have children, such as high blood pressure, diabetes, high cholesterol, and obesity. We know that all of those risk factors are unfortunately disproportionately higher in our communities of color, but they also lead more commonly to issues during pregnancy that could impact their future cardiac risks, such as preeclampsia or gestational diabetes or gestational hypertension. As such, it's also important to tie in the primary care clinician, somebody who always gets forgotten in the mix, because I will say, especially when it comes to maternal health, the first time a female tends to be reintroduced into the healthcare system is if they decide to have a child, and they can go and have gaps in between each and every one of those pregnancies. And that's why it's invaluable to ensure that after a delivery, not only are they receiving continuous care, but they're getting that care from a primary care clinician. So part of the team also includes that primary care doctor who's working with us as cardiologists, if need be, to optimize many of those largely preventable risk factors.
So that's really interesting. I was talking about pregnancy-related cardiovascular conditions and cardiometabolic conditions. And what you said was, it's not just when the woman becomes pregnant, it's even prior to that pregnancy, there should be a team approach to care, because those things are then going to manifest themselves during the time of pregnancy. So it's not just wait till you're pregnant and now get to a cardiologist, get to a diabetologist, et cetera.
May I get out of my lane for just a second? Because I so admire what Dr. Bond is doing and how much an impact this has. Because, my own view is that women have long had the unequal burden of childbearing, child rearing, and family stabilization. And that's especially true in communities of color. Now, that spectrum of responsibilities, as we've heard, provides a lot of opportunities for challenges to maintaining good overall health, stress, high blood pressure, pregnancy, weight gain, diabetes, and hormonal changes that contribute to bone loss, for example, just to name a few. Now, I wanted to point out that I heard a report last week about the alarming statistic that up to 1/3 of adolescent girls have thoughts about self-harm. And I couldn't help but wonder if somehow or another young girls of color end up being disproportionately represented in this disturbing psychological conundrum. Now, we really have to, because of things like this, remain vigilant, be attentive to signs and symptoms, and need to take to be more knowledgeable about how the physical and emotional health status changes across the lifespan in women of color. And that's something that I hope is increasingly being emphasized as part of this dynamic of how we're talking about this spectrum of problems that we are engaging.
Well, I honestly hadn't thought about that from that perspective, Dr. Gavin, but I'm glad you brought it up. Dr. Bond, any idea on what's happening with younger women who may now be having a sense of wanting to harm themselves? What's going on?
Well, absolutely. And I think it's extraordinarily relevant for us to raise those concerns because we do know that anxiety, stress, depression, all what we umbrella under the term psychosocial stressors, those are unfortunately independent risk factors for premature cardiovascular disease. We know that they do disproportionately cause a lot of these cardiometabolic risk factors that we're talking about. As such, we do as clinicians need to do a better job in screening for such conditions. I will say personally for myself, when I do see a patient for the first time, I'm actually doing a PHQ-9 test, which gives us the opportunity to see if they're having any form of depression. We also screen for anxiety, we screen for stress, and I'm educating my colleagues to do the same because particularly in communities of color, where the lived experiences from all those social determinants of health, negative aspects of it that they may experience, that will lead, unfortunately, into these poor outcomes. So I can't speak personally on the adolescents, but I can say that we know stress in of itself is impacting women of color, specifically Black women, and it makes sense that it's starting in the earliest of ages. But we as clinicians do need to put the onus on ourselves to make sure that we're screening for it, but more importantly, we're helping these particular vulnerable populations to also manage it appropriately.
Thank you for that answer. Dr. Gavin, I spoke about the fact that you as a diabetologist saw early the link between diabetes and heart disease and were an advocate of bringing those groups together. I remember that at one time we had in our medical curriculum that there was something called gestational diabetes, which was kind of a nuisance, but it went away at the time of delivery. That was pretty much an oversight. Is that correct?
Absolutely an oversight. And again, it represents the fact that this is an evolving area for all of us, the area of cardiometabolic disease. When does it start? Which systems does it include? And what is its evolution? I mean, what should we be on the alert for? And that's why I'm pleased to see the progress that we're making so that we don't lose sight of the fact that a person with gestational diabetes has now declared that they are in harm's way for the subsequent development of many of the cardiometabolic disorders that we are concerned about. A person with, quote, pre-diabetes, that person is already in the grips of a part of the spectrum of cardiometabolic disease. So we need to be more attentive. We shouldn't be casual about the way we make these designations or about the intensity of care and monitoring that we provide. So that was one of the reasons why I was so interested in hooking up with you cardiologists, because, from my early experiences, I found that my grandmother, my great grandmother, who I mentioned earlier, had amputations. I didn't learn until later that she had kidney failure. I had two uncles who had kidney failure, one who had a heart attack. You know what they all had in common other than being in my family? They had diabetes. So it was clear that there's something bigger going on here than just their blood sugars going up. And so that is really what launched me personally into looking at what I didn't even recognize then as the cardiometabolic disease spectrum. I just knew that a lot of different specialized medical disciplines needed to be in on caring for these people in order for their outcomes to be better. And that's why I hung out with you guys.
Those are fantastic insights. And I will tell you, James, that now having heard your story, I really now can understand how you could coming to the cardiology meetings and talking about the need to look at persons with diabetes and treat them more intensively and look at their cardiac risk, because you were seeing it. You knew it not just as an academician and as a researcher, but in your own personal life, you were seeing it.
Absolutely. And if I can just say one more thing, because I think what is encouraging to me is the fact that we need to develop a different model of care, okay, as different specialties across the cardiometabolic spectrum. Because when it involves diabetes, we are clearly on the same team. And that means we have to be embracing the same goals for outcomes. We want our patients to win and to live the best quality, longest possible life, unburdened by the morbidities of chronic complications. And we're talking about all patients with diabetes. We've been focusing on the disproportionality of some of the things that we are talking about, but this is true for every person that has diabetes. And you mentioned it earlier, Keith. We now share drugs that not only lower blood sugar, but they protect the heart, they protect the kidney, and who knows what else. We're still learning. So we have to adopt models of care that are more coordinated, more interactive, like a well-run coaching staff if we're going to win. Better communication, more clarity, more transparency, and more timeliness of response will be required to protect all systems in our patients. If you have concerns about what the judgment of your colleague who is in a different specialty, call him up, talk to him. Don't just make a judgment that he or she is kind of off, in the weeds. This is where we need better coordination. Collaboration for sure.
I'm gonna go into two areas that are somewhat controversial. The first, and I'll ask Dr. Bond first, is if a person doesn't identify as a woman, so they're not female, why should they care about women's health? And then James, I would say if a person is not self-identified as a person of color, you're talking about these disparities, these complications, end-stage renal disease, amputations, blindness. But if suppose a person says, well, I feel sorry for those people, so why should I care? Before you answer that question, that very provocative question, I am going to remind anyone who's listening, you can enter a question into the Q&A box at the bottom of your screen. And we're here, this is live, and we'll take your questions, we'll answer them as honestly and openly as we can. So that's a tough question. Dr. Bond, let's say if a person says, well, I'm not a lady, I feel sorry for them, but why should I care?
Yeah, no, that's a great question. And as you said, it's a challenging question sometimes for us to think outside the scope of just who we are as individuals. Now, I do think it's relevant for people to understand that the health of a female, let's say a female as specific, actually does impact your own health. It impacts the burden of the healthcare system, as an example, because if women are coming in being misdiagnosed, having worse outcomes when it comes to cardiovascular disease, dying at younger and younger ages, that's going to put a large burden on the healthcare system and eventually will trickle down to them. But beyond that, everyone has a female in their life. We have mothers, we have possibly sisters, we have possibly loved ones. So we want to think about this as it's not only helping the health of that female or that individual who may be different than me, it's actually helping my entire family. One thing that I will say since joining and having more leadership roles with an organization called the Association of Black Cardiologists is that I actually have began to realize the importance of family, the importance of what we do, how that could impact people that are in our household, possibly even our colleagues as well, something that we like to call generational health as well. So the health of myself, how will that impact those that come, past me and those maybe that have come before me? And I think that it's relevant for us to realize that even though you may not identify as that group that's having the greatest disparity, it is impacting someone in your family, but more importantly, it's also probably impacting you eventually down the road when it comes to the healthcare system and the overburden of disease that we're seeing that is largely preventable.
You articulate that so well. Dr. Gavin, the same question, and that's taken from the angle of race, ethnicity. A person who doesn't identify as an individual of color, who hears about this particular program and say, well, there they go again. I really don't care. Why should they care?
Well, I think Dr. Bond has talked about some of these same critical commonalities, because there is, independent of which group might be affected by the burden of these major diseases like diabetes and other aspects of the cardiometabolic spectrum, the burden that it puts on our healthcare system, the cost, is a cost to all of us. We share this common ground in terms of ultimately what has to happen in order to support a healthcare system and the burden that it bears. But there's something beyond that. What we learned from the experiences of one group with these common chronic conditions, those lessons help us in our design of strategies and approaches for all groups. And this is true whether we're talking about basic research or whether we're talking about how we should be changing the infrastructure in the lived environment. I'm chairman emeritus because I was founding chairman of a group called the Partnership for a Healthier America, which is still on an ongoing effort to really improve health and nutrition for American families and to do things like eliminate food deserts in communities. The lessons that we've learned by looking at communities that are disproportionately affected have helped us in the design of strategies across all communities. So we set up models and templates for how we can lift the boat of improvement for everybody by lessons that we learn, even when you're not really focusing on a particular group. We have to deal with disparities, and those are crucial steps in improving the lot of everybody.
Sometimes we'll look at the person who's uninsured and feel sorry for them, but don't really have a sense of wanting to address that. But if that person is admitted with heart failure or with an amputation or goes on dialysis, now everyone pays for it if they're disabled, because now they're going to be paid by the federal government, your tax dollars at work. So in a way, having these type of disparities in the wasted dollars, not only the morbidity and mortality, which is really the thing that drives our concern, but the wasted dollars should be the concern of everyone in the society. I think that you've articulated that, Dr. Gavin. You want to emphasize that a little bit more, especially since diabetes has such a high rate of complications.
Absolutely. And that's the thing that we should all be mindful of, the fact that at the end of the day, the chronic complications and the outcomes that we're most concerned about are high cost, long-term complications that drive up healthcare spending for all of us. It's not simply relegated to a sector. So if we are concerned about these kinds of outcomes and about the ability to improve healthcare outcomes broadly, we really have to see that it's important to prevent and diminish these kinds of complications across the board, especially where they tend to occur at the highest rates. And there's one other thing that we haven't talked about, and we've alluded to it. And that is that when we talk about premature mortality and premature morbidity that actually prevents a person from living their fullest life, we're also talking about the degree to which we diminish our talent pool. When people are not available, no matter what group they're from, when we lose access to the fullest possible life and the fullest possible contributions that a person can make because of the burden of chronic conditions, all of us suffer. And so this is something that we have to really see through a community lens. And that's why this issue of disparities becomes something that is a common cause for all of us.
Dr. Bond, you're one of the leading minds in the field of cardiovascular disease, specifically related to women's health, pregnancy-related diseases. But you're also very, very strong as an influencer on social media, Twitter and Instagram. I see you all the time. How do you handle the misinformation? I mean, it's really difficult. You're trying to get across positive concepts. Dr. Gavin has now articulated that we're all in the same boat. It's not whether you self-identify as a person of color. You've articulated it doesn't make a difference whether you self-identify as female. All of us share the disease burden. We share the cost. We share the loss of talent. But boy, you go on social media, some of the stuff is just ugly. How do you deal with all the misinformation?
Yeah, so yes, in the world of cancel culture, it's hard, right? But that being said, it's important that we stay true to the data, we stay true to the research. I will say that even this possible webinar may not necessarily be received as positively based on one's opinion. That being said, it's important that we still have these conversations, because when we're on the good side of history, explaining the historical context of why these disparities exist, which is largely what I'm doing on social media, is to educate why there is health inequity, why we're seeing sex disparities, gender disparities, race and ethnic disparities, but more importantly, how we could work to have strategies that could alleviate that. My hope is that I'm at least reaching one person out of the 99 others who may not want to hear it. And I will continue to do that. And I will say that a lot of other social media influencers do the same. It's challenging, but it's something that we have to do in this day and age, because what we want to do is aim more towards the younger generation, the Gen Zs, the millennials that are using social media, knowing that the earlier we get this information into the hands of people, the less likely we're going to see these poor outcomes. So I do think us as clinicians have to get more comfortable utilizing social media. I'm very proud to see Dr. Ferdinand as well as Dr. Gavin have their own social media accounts on Twitter, which is fantastic. But it really should come from the messengers that are providing that trusted information, such as people like ourselves that also identify with the communities that we're most targeting.
Dr. Gavin, you have any insights on how we combat this misinformation that comes on all angles, telling the population things which are frankly not based on any reality at times?
Yeah, that as we've talked about before, that's a really difficult one, because we don't have the appropriate degree of controls, nor do we have the appropriate authorities to stop it. You know, this is something that can be generated in a free-flowing way, and we really have to develop what I think Rachel just pointed out, more trusted sources of evidence-based information, and it needs to be accessible. You know, we can point people to places, but they need to be places that people don't have to go through too many hoops to get access to. We deal with, for example, in much of the work that we do in our community-based organization, Healing Our Village, we work with people who are not technologically savvy in many instances. And so if they have to go through a lot of technological hoops to find websites and then navigate a lot of links and things like that, as the only way they get to that source of trusted information, it's not going to work for them. So for them, we need to send them to people. Sometimes we need to hand them pieces of paper. We need to give them brochures. There's still a role for those kinds of devices. There's still a role for traditional things like educational programs and health fairs. So we do those kinds of things, trying to meet people where they are. And the final thing that I would say is that we've talked about this theme more than once in the course of this webinar, the importance of team-based care. Everybody that has a touch point with patients has to recognize the importance of this dynamic. So when I look at those standards of care that I talked about earlier, and I don't see any mention of the importance of the role of diabetes care and education specialists in helping patients navigate through the social determinants of health, then I'm disturbed, because it tells me that people are not looking comprehensively enough at the tools we have to activate in order to make a difference in these kinds of concerns. So I think that we just have to keep pushing it and developing more trusted sources and keep hammering away at what our individual and collective responsibility is, where we are in what we do on a day-to-day basis.
So well said. For the last few minutes, if anybody has any questions, again, you can put them in the Q&A and the moderator will bring them to my attention. But for the last few minutes, let's focus on some solutions. Dr. Bond, I know you have some writings and some legislative initiatives that you've worked with. Can you tell us some of the practical things that you're looking at to address some of the barriers that we have to improving women's health, including women who are with pregnancy? And Dr. Gavin, you'll follow with some really basic solutions to some of the disparities we see related to diabetes and its complications, and access to these very expensive, although powerful and beneficial medications. Dr. Bond, you go first. What are you doing to overcome some of these barriers?
Yeah, so, that approach is probably threefold. So it's education, first at the level of the clinician. I will say that when I was in medical school, even internal medicine training, I did not learn, or I was not taught, I should say, the sex disparities that we clearly see and we know exist. As such, I was privileged enough to have a mentor who taught them to me, showed me the way. And I will say that now we are changing the medical school curriculum, residency curriculum, and absolutely cardiovascular curriculum to talk about those sex disparities. So I do a lot of teaching in that realm. And I think that webinars like this give the opportunity from a broader perspective, not just to target clinicians, but also the community, because education to the community is key. You need to understand what your risk factors are. You need to ask these pertinent questions to your clinicians when you come into the doctor's office as well, or your clinician's office as well. So then there's the aspect of advocacy, something that I also am very privileged to have the opportunity to do through many of the cardiovascular societies that I volunteer my time with. One society in particular is the Association of Black Cardiologists, which I had mentioned, which is a non-for-profit that allows us to really hone in on communities of color and decrease the disparities that we see in cardiovascular disease. There, I actually am a co-chair of the Cardiovascular Disease in Women and Children Committee. And through that committee, we actually released a working agenda for Black mothers, which was a position paper that talked about the collaboration, how cardiologists, along with obstetricians, along with primary care physicians, et cetera, need to work together with the patient at the center to improve these despairing outcomes that we see. But also through this council, we've done a lot of legislation to change the amount of policies that we know are impacting communities of color. Specifically, as an example, extending postpartum coverage from the standard 60 days to up to 1 year. And I'm happy to see that several states, more than half the states in the United States, have actually allowed this, but we still obviously have work to go because it's about 26 of the 50 states. So we have a lot of work to do, but at least these conversations are happening. And I am very privileged they have the opportunity to go to Washington, D.C. to explain the importance of why these policies need to be in place to ensure that we have coverage all the way through that 1 year after delivery, and then hopefully beyond. That way we can decrease the rates of these very preventable cardiovascular complications.
Well, you really put that on the radar for all of us to take into account, that it's not just during the pregnancy itself, but extending the benefits of having coverage up to a year really can make a difference. And that's something we should look at. Dr. Gavin, you've been the lead of multiple organizations. We know that we now have diabetes education is covered. We still have some difficulty with these medications, but just give me some practical solutions to overcome disparities in diabetes care.
So I think some of them have been touched on already. We cannot overemphasize the importance of ongoing health education. You cannot address a problem when you don't know you have a problem, and you don't know the nature of the problem. You won't ever define appropriate strategies to relieve it. So we continue to emphasize the importance of evidence-based factual health education, and for that reason, we continue. I say we, I'm talking about organizations that I work with at community level and at the national level. We continue to develop outreach programs to coordinate community-based activities, like I mentioned before, including old-fashioned things like health fairs. We work with things like religious ministries, church-based ministries. There's still a lot of people that can be reached in those kinds of settings. And we use the full spectrum of resources that are available from pharma companies and from governmental agencies. Remember that the National Diabetes Education Program, which is a combination of the NIH and the CDC, was put in place. I'm a former national chair of the National Diabetes Education Program, was developed for the purpose of making sure that state-of-the-art current information about diabetes for patients and providers is always going to be made available for free. Okay, you've already paid for it through tax dollars, and that information is available on demand. And organizations like the American Diabetes Association, you've heard Dr. Bond talk about the Association of Black Cardiologists, but there are other organizations that are in the fight that serve as means of getting information to patients and providers. But very often we need patient-based information in an urgent way. Blackdoctors.org. There are many of these kinds of organizations that are now engaging in a more substantive way to make sure that these kinds of strategies are available. And then finally, the whole issue of advocacy. You know, you heard a lot about putting a cap on insulin costs in the last year, the $35 maximum for insulin. Well, that is the result of advocacy. The amount of medical education and diabetes self-management education that is covered, those are results of advocacy. We have to keep identifying what are the touch points that patients need in the era of disparities through advocacy and policy-based initiatives that are going to move the needle and make the most difference. And we are working on those day and night through various levels, including organizations of the type that I just summarized.
Dr. Gavin, Dr. Bond, you are two of the most dynamic people that I know. You took on the task of covering a wide range of concepts, very complex concepts, but I think you articulated them for our audience in a way that's very digestible. Perhaps now you can give us just some take-home points, just a few minutes, some things that, if they said one thing you wanted them to remember, or two things you wanted them to remember from participating in this webinar. Dr. Bond, I'll let you go first, and then Dr. Gavin, you'll give the last take-home point.
Well, first, I think this was an amazing hour. Can't believe it went by this quickly. But what I would think that would be great for those that were listening to take home would be, it is such an important aspect that when we as clinicians are taking a medical history, that we incorporate those social determinants into it. And as patients possibly listening in as well, it's important that if your clinician isn't incorporating those into the discussion, you're offering that to them, because it does impact where we can or how we can best manage you. We know as it stands, about 80% of our health is dictated by these social determinants of health. And it's important that we have them part of the conversation. We may, as clinicians, not be able to help improve them, but we could at least make it easier for you to access some of these medications that we discussed today, some of the treatments, some of the management, but we won't be able to do that unless we understand some of those roadblocks and some of the challenges that you may experience and may have. The other thing that I think is relevant is that it's very important for us to acknowledge that these disparities do exist. And as we said, it doesn't matter if you come from the communities that we're addressing, be it the Black and Brown community or women in particular. It impacts us all. And I think when we begin to think about healthcare and the impact healthcare has on all of us, that's when we're actually going to make changes. So that is what I will leave you with. Thank you.
Dr. Gavin, thank you for a lifetime of service and leadership. Thank you for taking this opportunity to talk to us about some of your ideas. Can you give us a take-home message?
Well, I think Dr. Bond has really captured a lot of what I feel. I think it's really important to emphasize there's much work to be done, and no matter who you are or what you do in the healthcare space, in the cardiometabolic space, you have to embrace the team approach to patient care. That's the only way that we can really take advantage of all the new tools and understandings that we have developed to help patients win. We have to make sure that the silos are never given a chance to rise again. The integrated approach to care, cross-disciplinary care, is a must. We didn't talk about it before, but we need to make sure that we exchange emails and maybe even cell phone numbers so that we can talk across specialties when there's a concern about a patient, okay? And the final thing that I would say is that I want to invite people to take part in the public comment period on the report of the Health Disparities and Health Equity Working Group of NIDDK's Advisory Council. That is right now. It's from February 14th to March 17th. Go to that website and read that report, and then ask yourself, how can our organizations be more involved in moving this vitally needed research agenda in health disparities forward? All of us have a vital role to play, and I invite you to take advantage of this comment period right now to read that report and make a comment on it.
Thank you so much. Moderator, do you have any closing comments for us?
We do have a couple of questions from the audience. So again, Dr. Ferdinand, if there's anything that you want to wrap up and say, just let me know.
Well, we only have a minute. What I think we can do is accept them at the email of IMFO at cardiometabolichealth.org, and we can try to get answers to them. But go on and give them to me really quickly, and perhaps we can do them in a few seconds. What are the two questions?
Of course. So the first question that we have is, what can be done about the representation of women and racial minorities in clinical trials? Can pharma also help clinicians with this?
Yeah, that's a really big one. Dr. Bond, expanding clinical trials to be more inclusive. I know that you've spoken directly about that, Dr. James. Clinical trials, equity in clinical trials.
That's actually extremely important. We know that at least from a cardiovascular trial perspective, when it comes to women in particular, about 30% of the time women are enrolled in trials, including trials on coronary artery disease or congestive heart failure. What we are trying to do is to not only make sure that we're targeting those populations, but we're also diversifying the population that are principal investigators. So as it stands right now in the cardiovascular field, we have a underrepresentation of women, specifically women of color. And as such, we see that as a move further up in the ladder, even when it comes to research and being principal investigators. So I think the easiest step for us is to make sure that the population we want to target is reflected in the leadership and who's actually overseeing the trials itself. So something that all of our cardiovascular societies have been working on, I would say, is key. And then to that same point, which I'm sure Dr. Gavin can expand on, is working with the communities to really make sure that, as he very nicely said, we go to the grassroots effort and meet these particular patients where they are instead of having them come to us. So I'll let Dr. Gavin expand a little bit on that.
Dr. Gavin?
I would simply quickly say that one of the things that's highlighted in that NIDDK working group report is the need to really look carefully at what the interaction needs to be with community-based organizations, because we're not going to be able to make headway on questions like this unless there is more effective and meaningful integration of community-based organizations in our research agenda. And we need to take that really seriously and put some teeth in it, okay, so that you don't certify a trial as having met its appropriate standards for success unless certain levels of representation are assured.
One more question, real short answers, and then we're going to close.
Sure. Our next question asks, and give me just one moment, how can we better teach our colleagues to get the word out in addressing these disparities?
Well, I'm going to take that one. The whole purpose of this webinar was for the Cardiometabolic Health Congress to allow our voices to be heard, but not to represent a particular racial or ethnic group or sex or gender, but to bring all of us together to decrease morbidity and mortality across cardiometabolic conditions, and to recognize that whether you self-identify as a woman or someone who's Black or Hispanic or Asian, it doesn't make a difference. We all share in the cost and the loss of talent from early death and disability. So that was the whole purpose of this. It wasn't to talk about one group is better than another or try to shame or to separate people, but to recognize that all of us will benefit from reducing and really eliminating these disparities related to sex, gender, socioeconomic status, race, ethnicity, or geography. If we don't do that, then we won't have a just society. So I think that's great. We have one more thing. I'm going to give some closing announcements about what Cardiometabolic Health Congress is doing. Before I do that, I want to thank my wonderful colleagues and great friends, Dr. Gavin, Dr. Bond. Thank you for your opinions and your insights.
Thank you. Bye.
Thank you.
So throughout the year, the Cardiometabolic Health Congress has several meetings spanning diverse ranges of topics in the cardiometabolic health space. We invite you to join us in Orlando for the spring program. That's going to be from May 19th to May 20th. There also will be a masterclass focusing on women's health and wellness, August 17th to August 20th in Southern California. And finally, you can join us in Boston for our 18th annual meeting, which will be from October 11th to 14th. Visit the CMHC website for more details. I appreciate the fact that in the middle of a very busy day, you took time to listen to us, and hopefully we've stimulated you to become an activist in helping us all achieve health equity. Thank you again for joining this afternoon, and have a good evening.